Welcome to our webinar. Today's webinar will focus a bit more on the clinical value of our icobrain MS product. Many of you might experience that radiology is rapidly changing today. And we believe that it is an era of change. There is a new era entering. After the big inventions of the CT in the early 70s and MRI in the late 70s, there was the complete digitalization of radiology in the early 90s with the introduction of the PACS systems worldwide. And today, I believe we are entering a new era, the era of artificial intelligence. And it's our belief that artificial intelligence will not only change radiology, but also the profession as a radiologist. And there are some good reasons that artificial intelligence will enter radiology. This is some research that has been done by Simon Harris, who is working for the market research company Signify Research, who identified 5 main reasons why radiology is needing AI. First of all, there is a global shortage of radiologists, especially since the number of images is ever increasing, not only because there are more modalities, but also the acquisition times are getting shorter and shorter. So that means that the number of images is ever increasing. On the other hand, the number of radiologists is not increasing at the same pace, and in some countries it's even getting lower. So that puts some high workload on the individual radiologist and asks for an enhanced productivity. And that's where AI can help with, to help the radiologist with some simple tasks that cost time, but can make his life much easier and more productive. On the other hand, we see also that our patients are changing today. Today, they are often more empowered and asked for a better diagnostic accuracy and demand lower rates of misdiagnosis to have, in the end, an improved patient outcome. And with all of these elements, artificial intelligence can help with. And with icobrain, which is our software that we developed at icometrix, we want to add artificial intelligence into the brain to enhance the productivity of our users, to improve the diagnostic accuracy, and to improve patient outcomes. icobrain is today used for patients with multiple sclerosis, dementia, and traumatic brain injury, but many other disease domains will follow in the future. We have chosen with icobrain to be a background service, meaning that we believe the radiologist is not asking for another application to work with. So that means that images are directly sent from PACS or scanner via a DICOM router to our secure cloud, in which they are processed. And the results are put back into the PACS before the radiologist starts reading. So all of this is happening before the radiologist is seeing the images. And this allows a flawless and seamless integration into the clinical workflow. It also allows the radiologist to look at our results in his familiar viewer, so there is no need for an additional or specific viewer to look at our results. Today, we have a portfolio of 5 FDA cleared and CE marked reports used for patients with multiple sclerosis, dementia, and traumatic brain injury, which are the reports for icobrain MS, icobrain DM, and icobrain TBI. Today's webinar will focus on icobrain MS, which is used in patients with multiple sclerosis. And I will guide you first through the report, which consists of 2 pages. The first page is reflecting the inflammatory aspect of the disease. So what you can see here, which is the first page of the report, you can see the quantification of the flare white matter hyperintensities, which can correspond to the white matter lesions in MS. The second page of our icobrain MS report focuses on the neurodegenerative aspect of the disease. We measure the whole brain and gray matter volumes and also the volume changes. So it gives an indication of the brain atrophy that is present in the patient. Besides our quantitative reports, we also provide back segmentations overlaid on the original images. And we send them back as DICOM images, so they are stored together with the original images in the PACS system. The third output of our software, which we recently launched and is of particular interest of today's webinar, is the natural language report. The natural language report tries to translate our quantitative reports into a natural language that can be used as a template to start from for the radiological reporting. So the natural language report is sent back as a DICOM structured report and is also available in the PACS system. This allows to copy paste the text into your radiological reporting software and start adapting from there. But as a result, most of the information present and found by our software is already present in the natural language report. And as you can imagine, this will speed up the process of the reading, and moreover, it will enhance the consistency of the reading as it always starts from the same template. Let me dive now into a concrete clinical case. So this is a 37-year-old patient with a history of multiple sclerosis. The patient had a problem of extremity weaknesses and had an increasing loss of balance over the last 2 weeks. So the last scan was acquired on March 27 in 2017, and there was also a scan acquired a bit more than 7 months ago on August 9th, 2016, which was also available for comparison. So as you can acknowledge, when scrolling through these two images, it's not easy to see where there is new lesion activity. And an important reason is that the scans are not perfectly aligned. Moreover, this is a patient with a rather high lesion load, which makes it also more difficult to see where and whether there are new lesions. Let me show you in the next slide the report that the neuroradiologist made for this particular scan. This is a report that was generated without the use of our software. And I'll focus on the conclusion for now. So this neuroradiologist concluded that there was a favorable evolution with the disappearance of one and the regression of several other lesions. There is also an impression of slight cortical atrophy compared to the previous examination. So we asked this neuroradiologist to do the report again, but starting from our reports and our natural language reports and our overlaid segmentations. You can see here the quantitative report with the focus on the first page, which is about the inflammation. So the lesion inflammation is there. And on the right side, you can see the overlay with the new lesions indicated in red, the stable lesions in green, and the enlarging lesions in orange. Starting from our natural language report, the neuroradiologist concluded that there is periventricular juxtacortical white matter lesions consistent with the diagnosis of multiple sclerosis, that over a course of 7 months, there is a lesion change compared to the prior study, with lesion change as follows: a total volume of 0.46 milliliters, and that corresponds to 2.7% compared to prior study. And what's important as well, that the neuroradiologist found 2 new lesions based on our reports. Moreover, also there was a quantification of the annualized atrophy, which is more than what is to be expected in normal controls, and that is also reported in this in this radiological report, also with numbers this time. The neuroradiologist could simply copy this report from our natural language report and update it where necessary. So, and that brings me actually to the benefits of using icobrain MS in the practice of radiological reporting of multiple sclerosis cases. We could demonstrate that this enhanced the productivity of our users with about 60% by faster and more consistent reporting. And as such, we can reduce the workload and the variability that exists in the reporting of multiple sclerosis cases that are today. Second, we can better detect disease progression by the accurate assessment of subclinical disease activity, which allows a better follow-up of the patients. And finally, we have been able to demonstrate in a theoretical model that the time on a suboptimal treatment could be reduced with 32 months. Let me dive into each of these aspects a bit deeper. So first, there is the enhanced productivity that we demonstrated in some work that will be published soon, where we demonstrated that without our software, the radiologist can read 8 cases every hour, but using our software, including the natural language reporting, the radiologist, the neuroradiologist could read 13 cases every hour. And in this case, the neuroradiologist was familiar with our natural language reports, but was not intensively trained on them. So it can be expected that the increase in productivity, which is here about 60%, could potentially even higher in cases that the neuroradiologist is highly trained in the natural language reporting. Also, we have done another study which was published in 2018 that demonstrated a reduced variability, both an intra-rater variability and an inter-rater variability. Here you can see, and then I focus on the arrow at the top of the slide, that the intra-rater agreement increases from 91.7 to 97.8%. So a clear increase in intra-rater agreement. Also, the inter-rater agreement increased from 85.9% to 90.7%, making the inter-rater variability and inter-rater agreement now more or less at the same level as the intra-rater variability before using the software. The second benefit of using icobrain MS is the better detection of disease progression. And this is also work that we have submitted and will be published soon, where we could demonstrate that disease progression can be detected much better using our icobrain MS software. On the left side, you see a graph where the software was not used, and in a cohort, only 24% of the cases was considered progressive. When using our software, this amount went up to 44% of progressive cases. And then there was also 32% where a slight progression was found by our software together with the neuroradiologist using the software. And only 24% of the cases were stable. So this slide indicates that that using the software improves the accuracy of detecting disease progression in multiple sclerosis. Then the question is, how can we use this information when treating patients? And it's interesting to see that in the last years, there have been published some guidelines that range from conservative to more progressive on the treatment of multiple sclerosis patients. There are the AAN guidelines by the American Academy of Neurology. the European guidelines of the European Academy of Neurology and the European MS Society. And finally, the brain health recommendation, which are also endorsed by most multiple sclerosis societies and neurology societies. The EAN ACTRIMS guidelines for MRI mostly correspond to the NIDA-3 criterions, where NIDA stands for no evidence of disease activity. And NIDA-3 means there is no evidence of disease activity according to 3 axes. There is no relapses and no increase of EDSS, that's the clinical axis. And there is also no MRI activity, and this is particularly focusing on lesion activity. The brain health recommendation correspond more to the NIDA-4 criteria, where there is an extra element, which is the brain atrophy. So there is no abnormal brain atrophy allowed to have to declare the patient as no evidence of disease activity. So when looking at our cohort, it is interesting when we compare these different treatment guidelines. Here you can see a graph where we compare the different treatment guidelines. With in gray, the percentage which allows, according to the guidelines, a treatment switch. So the cases where a treatment switch should be considered. And in blue, the same, but for when the software icobrain MS was used. So you can see that there is, even in the conservative guidelines from the AAN, a higher percentage where treatment switch should be considered, because even for these cases, some disease activity was found. But if we look on the right side, there are the more progressive guidelines. And these progressive guidelines can also be interpreted in different ways, especially the aspect of brain atrophy. And that's what you can see on the 4 most right bars. There is NIDA-4 and brain health, which correspond to each other, where we distinguish between having an atrophy that is 0.5% larger than the normal atrophy for that age. And also the case where we define disease progression when there is atrophy more 0.2% more atrophy than as expected for that age and gender. So you can see, especially on the right side, that much more patients are probably progressing, which cannot be seen without using icobrain. And the more progressive guidelines you use, the more value there is in using the icobrain MS software. I also need to note that the percentages shown in this study might not be generalizable for the whole population of multiple sclerosis. And then, of course, the aim is to reduce the time on a suboptimal treatment. And today we know from literature that approximately 25% of multiple sclerosis patients start on a suboptimal treatment. And unfortunately, it takes quite some time before they switch. And according to the paper of Rio in 2012, this is 47 months today. But when we would use the more strict guidelines, meaning NIDA-4 in this case, we can reduce the time on suboptimal treatment with 32 months to have only 15 months of suboptimal treatment, months of time on a suboptimal treatment. An important factor to reduce that is, of course, brain atrophy. And what is interesting is that recently there have been some publications that compare different multiple sclerosis medications on brain atrophy. And this is an interesting one, is the one from Favoretto, published in 2018, where he compared different medications. And a selection is presented in this figure, where you can see that fingolimod and alemtuzumab could reduce the brain atrophy to a level that is also present in healthy individuals, whereas other medications do not have the same effect. Something I also want to stress is that it is important to have another baseline approximately 10 to 12 months after the treatment has started. And that is also shown by this publication of Branger in 2016, where first-line medication is compared to second-line medication looking at brain atrophy. And there was no significant effect found in this meta-analysis when there was no rebaselining done. And this can be explained by the pseudoatrophy that typically occurs when a patient starts a second-line treatment. So when taking this pseudoatrophy into account and do a rebaselining, and there is a significant change between first line and second line treatment, where of course the second line treatment has better effects on brain atrophy than first line treatments. So with that, I want to conclude the presentation, which is the first part of our webinar, with the main takeaway points from this presentation. And I think it is important to realize that icobrain MS allows a faster reading. We demonstrated that the productivity could be increased with 60%. It also allows a more consistent reading with a decreased inter and intra-rater variability. It allows also a better detection of disease progression. And it allows the practical implementation of treatment guidelines considering brain atrophy, like there is, for example, NIDA-4 and the Brain Health Report written by Professor Giovannoni from Bart's Hospital. And taking all these aspects into account, I am sure there is a way that we can improve the outcomes of our multiple sclerosis patients by reducing the time on a suboptimal treatment. And with that, I would like to thank you all for your attention. I would also like to invite you to subscribe to the icometrix newsletter simply by browsing to our website, icometrix.com, where you can subscribe yourself to our newsletter.